Well, good afternoon, everyone. Welcome to another Lown webinar series. Here we are in May. I'm Allison Kelly Hedgepath, joined by Dara Lee Lewis. And we have some other Lown guests today. Dr. Brian Bilchek, our nurse practitioner, Jonathan Gerbaud-Grant, and our exercise physiologist, Nicole Govea. Welcome, everybody. So I'll go ahead and share my screen here. We are going to be talking today about cardiorespiratory fitness and cardiopulmonary testing. So we're going to briefly start with an overview as to why your cardiorespiratory fitness is important. And then I'm going to hand the screen over to both Nicole and Jonathan, and we're going to talk about some of the specifics of testing. And then we actually have 3 case presentations we're going to go through, and we will save lots of time to take everybody's question and answer. Okay, well, let's just dive right in by reviewing what the official recommendations are for everybody's weekly exercise requirements. So these are the recommendations by the American College of Cardiology and the American Heart Association. They should be something that you're all familiar with. So we recommend at least 150 minutes a week of moderate activity, moderate intensity activity, or 75 minutes a week of vigorous aerobic activity. And in addition to that, we recommend 2 days of strength training to increase your muscle mass. And it's unfortunately estimated that only 1 out of 5 adults in the US actually hit this every week, right? So really important for us to be repeating, really important for each of us to have a plan for ourselves. And definitely for all of our patients, we want to be really personal in helping you to create this prescription. So I'm going to start off just with a really big overview about what cardiorespiratory fitness is. So when we talk about your fitness level, we're talking about the capacity of the circulatory system, which is your heart and your blood vessels, and your respiratory system or your pulmonary system, your lungs, to deliver oxygen to skeletal muscle mitochondria for energy production that's needed for physical activity. So when we talk about your personal fitness level, we're really talking about 3 systems: your circulatory system, your lungs, your pulmonary system, and then your skeletal muscle system that we are assessing. So we can do this by measuring your fitness in a test. When we do a cardiopulmonary test or a CPET test, we actually measure the VO2 max, and we're going to go through some examples of this test today. When we do regular stress testing, which perhaps many of you in the audience have done before, we actually estimate from a standard protocol, and we'll give you some examples of this as well, what your metabolic equivalent is, right? So in the CPET test, we measure your VO2 max and then actually have a measured MET. In other testing, we use a standard protocol where we estimate your metabolic equivalent. And that's a term that you might have heard before. This is a simple graph that just shows examples of some activities that are commonly done and what the metabolic equivalent is. So if you're just sitting, as you're sitting there watching me now, that's 1 metabolic equivalent. If you walk up a flight of stairs, that's 4. And then if you're doing vigorous exercise, that can be, upwards of 10. And when we do stress testing, we have a performance level that's designated in each of the reports that kind of give us an idea of where your fitness level is based on these METs. So I want to share with everyone a few details about why your cardiorespiratory fitness is important, and then we're going to jump into the details of testing. So this is from a study published in 2018 talking about how VO2 max is a predictor of longevity, and it has some really nice graphs in the study. So this shows us where our VO2 max is, and it plots it by age. So this is important to all of us because what you can see from these three lines is that as we get older, our fitness level declines. But the really powerful takeaway from this is that if you are a trained individual, and here lifelong endurance athletes that are male are shown in this top line, and women are shown in this dotted line in the middle, your cardiorespiratory fitness starts at a higher place. And even though it declines as we age, you still end up at a really high fitness level. And that should really be the goal for all of us, right? That no matter what our age, we're really working on our fitness level and improving that as much as we possibly can. And the reason that we talk so much about exercise is it really has pretty potent health benefits. So on this busy graph, we're looking at your physical fitness level, and again, by age, right? And so obviously exercising improves our quality of life, but we have some really good data that it actually probably improves the length of your life as well. On this graph, we're really looking at the minimum amount of physical activity it takes to remain independent. And I think when I talk to patients about how they think about their later years in life, everyone wants to be independent as long as possible. And at some point, our physical activity level declines so much that we're no longer able to care for ourselves. And I think this graph represents how we can really strive to be on this train line where you can see it's crossing your minimum physical fitness level here as late as possible in life. So we can all live as long as possible doing the things that we want to do. And that is the goal with exercise and excellent cardiovascular care. So I'm going to share with you some really well done data that I hope you will find inspirational as you're thinking about your own exercise training regimen. I'm going to start with this article that was published in JAMA in 2018. This was a really large study that enrolled over 120,000 healthy adults who came in for stress testing and have followed them for about a decade out. And when we look at survival by exercise group, we see this really beautiful dose response. So this line here in the light blue are those with a low level of fitness and unfortunately at risk for surviving the least, right? As we go up in your fitness level, we see below average, average, and then high fitness levels and elite live the longest and do the best. So that's what we're all really striving for, is to be in that category. We can look at this another way. If we look at our risk of mortality, we can see that the mortality goes down as our exercise capacity goes up. And I show you the second graph here just because it splits men and women apart, and we see a very similar graph by gender. So importantly, in this study, they provide us with the metabolic equivalents and how they labeled your exercise fitness group. This is for women at the top part of this graph and by men on the lower part. And you can find your age group. And if you've had a stress test done, you can find where you fall on here and actually estimate where you are in terms of your exercise tolerance. And I do think that this is something that everybody should know and be thinking about as we train, especially if we're really training for longevity, to make sure we're always working towards a goal of being as fit as possible. I'm going to jump into the second trial. This is published in the Journal of the American College of Cardiology, also in 2018. In this study, they took 4,000 healthy volunteers and they did CPET testing. So this time we're not just estimating performance, we're actually collecting the expired gas exchange, which Nicole's going to show us in the next few slides. But they looked at both men at the top and women down below and followed these patients for 25 years. And we see here a similar story that the patients that are the most fit have the longest lifespan. So really powerful data on predicting our cardiovascular health. And the final trial that I really want to share with you was published in the Journal of American Cardiology in 2022. This study enrolled over 750,000 veterans. And the fun thing about this study is it was a large age span. So they enrolled patients in their 30s all the way up to their 90s, with a significant proportion of patients in their 70s and 80s. And what did we find in this trial? Well, very similar results to the other graphs I've shown you, a dose response curve, right? So here, plotting survival, those with the poorest exercise capacity had the worst survival, and a nice dose response for every fitness level. And that was true in the whole cohort. That was true when we excluded people that had comorbidities. That was true when we just looked at men and when we just looked at women. So really powerful data. And all of us should really feel inspired to be as fit as possible. I'm going to show you one more slide from this study, and I like the way this is done, even though it seems a little bit busy. They looked at your relative risk of death, and they divided it up by age group. So this first group here is 30 to 49. The second group is 50 to 59, then your 60s, your 70s, and then the group 80 to 95. And you can see as your fitness level improves, your risk of dying goes down in a stepwise manner. And it's really powerful to see this is true even in your later years. So it's never too soon to start training for exercise. The other thing they did in this graph is they put this red bar at the level of fitness where they saw a 50% reduction in mortality for that age group. Okay, so we are always happy to share this data with patients going forward, but these numbers here are really powerful, right? So for each of these age groups, we really want to be exercising and make sure our fitness level is as high as it can be, and hopefully higher than the red bar for each of us. Okay, if I haven't convinced you of the importance of exercise, I'm going to just show a couple more slides, because we do get asked, well, what if you're not healthy and you have comorbidities? Is exercise still as beneficial? And the answer is yes. So again, this dark bar are the fittest people, and we see this dose response that you do better over time, lower risk of death in the highest, in the group that can do the most exercise. And that's true if you have high blood pressure. It's true if you have COPD. It's true if you have diabetes. It's true if you're a smoker, if you are obese with an elevated BMI, and if you have total cholesterol. We've also looked at this in patients that have coronary disease, which of course, we follow many of these patients here in our office, but in the white bars here, we see this nice dose response that the fitter you are, the longer you live with coronary disease. So, so hopefully I've convinced you of the importance of exercise. This is a really busy slide that I just want to say that, you know, for our patients, if we could give you one prescription, it would probably be the prescription of exercise, because when you choose to do it in a habitual way, you really are affecting multiple systems, your endothelial function, the signaling between cells, how our cells are walling off our plaques and stabilizing them, how we're triggering blood vessel growth and remodeling in our heart, some of the hormones that affect cell signaling, and then of course training on the musculoskeletal level as well. So some really profound physiologic effects from exercise. Okay, with that whirlwind of epidemiology, I'm going to turn this over to Nicole and Jonathan to talk us through these next few slides in actual testing.
Wow, thanks, Allison, so much. You know, every time that we go through all of this data, I think I should be currently exercising as we do it. There's so much proof and so much data there, and it's so numbers heavy that, you know, I often think to myself, you know, how much exercise should we be doing? And since there's such a dose response to exercise and longevity and health span, we kind of need to look at, you know, how much really should we be doing? And it sort of needs to be patient specific. So one way that we can do that, one way we can make recommendations is by having someone come in and testing them in the office. And there's a couple different types of tests that we do here. There's basically ETT or CPET, so exercise tolerance test, or the test that people are more familiar with. and the cardiopulmonary exercise test. And we basically use these both two methods to evaluate fitness, disease states, and symptoms, and then to provide recommendations for exercise after that. Okay, so this slide, which we all have come to enjoy and love, is basically a graphic representation of the intertwinings between muscular, circulatory, and ventilatory systems. And I just put it on here, not just because we like it, but because it's important to understand that level of fitness doesn't just focus on one part of the human body. It really looks at muscle, the heart, and the respiratory system that all work together to meet the demands of our body. And when we go through testing, that testing can help us identify, which, if there is a limiting factor, which is the limiting factor among these. So the first one, sort of like I was saying, this is a little bit of a review. So the exercise tolerance test that we often do for patients in the office, most of our cardiac patients are familiar with this test. The exercise stress test that we do on a treadmill is typically cardiac focused. So we look for cardiac abnormalities during this test that can typically look at large blockages in the major vessels of the heart that cause ischemia and these sort of arrhythmia. And we can evaluate symptoms and look at both the heart rate and blood pressure response to exercise as we increase load. And then we have this sort of derived piece called the METs, which is the metabolic equivalent, which is a number that gives us your basically your exercise capacity at a given time. And next, Nicole is going to talk about the procedure for doing the test.
Thanks, Jonathan. So when you come in for an ETT, the first thing that we'll do is place 10 electrode stickers on your chest. And this connects to our ECG machine, which allows us to monitor your heart rhythm throughout the entire test. We then get baseline vitals, such as your heart rate or your blood pressure in both a laying and a standing position. Then once we've got all of our baseline data, we get you exercising on the treadmill. We use the standard Bruce protocol. So if you look at that chart there, the Bruce is divided into 7 stages, and each stage is 3 minutes. And you can tell from the first stage that a speed of 1.7 miles per hour and a grade of a 10% incline is relatively easy. As you progress, however, it does get harder. The goal is for you to exercise until you've reached a maximal or a near maximal effort. Once you're done exercising, we slow the treadmill and continuously monitor you as you cool down. From all this data that we collect during the test, we can write the report that would include your ECG rhythm interpretation, your max or your peak heart rate, blood pressure, how long you exercised for, and what that would equate to in METs.
Great. So we already talked about this more cardiac focused test called the exercise tolerance test. And the next test that we kind of want to focus on is the CPET. So this is a full body systems analysis of your current cardiorespiratory status. So we essentially evaluate this complex series of events called cellular respiration, which is a combination. And this slide looks busy, and we're not going to go through it in very much detail, or Allison would be upset with me. But it's essentially this three-part process that includes glycolysis, the citric acid cycle, and oxidative phosphorylation, which is a complex way of saying, how does my body use fuel to produce gas and energy? And in the end of our CPET, we can get data that can help make recommendations for exercise. Most data that we talk about in this is ventilatory data, but also this piece of information that you're all probably starting to become familiar with, but this VO2, this volume of oxygen that you can absorb. There's a threshold number and there's also a max number, and both of them can be really useful in creating exercise and training plan recommendations.
So for the CPET, it's essentially the same setup as the stress test. So we'll hook you up to our ECG. We get those same baseline values. Then we'll give you some nose clips and a mouthpiece, and this is called a pulmonary function test or spirometry. which many of you may have done. It's where you take that huge breath in and then you blast it out super strong. We measure how well you're just moving air in and out of your lungs. You'll also wear an oxygen saturation monitor as you exercise. Typically, we do this on the bike, and so you'll have a period of a warm-up. Then resistance will be added to the bike, so it will just slowly feel harder and harder to push those pedals. While you're exercising, you'll wear the face mask that you see on the right there, and this is what captures all of those breaths. Until you've reached your max or your near max level, we'll have you stay on the bike and cycle for a few minutes as you cool down and as we monitor all of that data. Because there's a lot more equipment used in the CPET, we get a little bit more information, and our report can include, similar to the stress test, your ECG interpretation, your peak or your max workload, and then it also includes your metabolic, cardiovascular, and pulmonary data. And so here you'll see an example of me doing a CPET on the bike. You can see the ECG machine strapped onto my waist and that nice looking face mask.
Okay, so in Nicole's previous slide on CPET, you probably saw in the report, there's a lot of different types of data that we can collect: metabolic data, cardiovascular and pulmonary data. And, how do we really go about using that? So we can evaluate people's disease state and make diagnosis in terms of their health, but we can also use this to provide recommendations to exercise, and was sort of the point we're talking about here. So this chart over here on the right is it's like one of the examples of zones that we can create. So this is the Cog Power Zones. It's basically a cycling specific power zone chart developed by Dr. Coggin, who said that for a certain threshold heart rate or a certain threshold power, you can develop different zones to exercise at. And then we can make recommendations based off of the current patient's health state and fitness state of where to go next from here. So this can be from a patient that has very minimal training background to a patient that's exercising very vigorously on a regular basis and has been for essentially life. So we can target specific areas of fitness, but also making sure that we really manage the workload and avoid overtraining. So our patient population has a tendency to be very motivated once they get the data and understand how important it is. And then we have a tendency to kind of use the mentality that, well, in the rest of my life, I've been able to just work hard and really achieve my goals, and the more work I put into it, the better. And although there's a dose response for exercise and being healthy, going overboard is equally as bad as not doing anything if it doesn't allow you to progress in the long term. So they can be adjusted for personal goals as well as your health history. Okay, so we're going to go through a few patient cases. So these are actually real world cases of patients that have come into the office to see the cardiologist and myself and Nicole and Allie to develop exercise plans and exercise recommendations. And we'll kind of talk about some both typical and atypical barriers to exercise. We'll go through basically their history, some testing, and then how they can individually benefit from exercise, and then our recommendations for it as well.
So our first patient case is a 56-year-old female professor and mother of 2 kids. The medical history includes palpitations, hypothyroidism, metabolic syndrome, borderline high blood pressure, a history of an ACL tear, a prior leg fracture, arthritis, and vertigo. For medications, she currently takes metoprolol, a statin, levothyroxine, meclizine, and ibuprofen as needed. Her exercise history: she's a former recreational runner who currently walks 5 days a week at lunch and before dinner, sometimes on the weekends. So she came in for an ETT. This test was limited by knee pain. However, her heart rate and her blood pressure response were normal. She had no arrhythmias on her ECG, no ischemia. she achieved a total of 7.8 METs. And compared to her previous test, her heart rate and her endurance time have decreased.
Yeah, so when we look at this particular patient, we have a lot of information on their background, their current exercise status, and then how they did on their testing when they came in, right? So we have a patient here that's 56 years old. She achieved 7.8 METs on her exercise test, but was slightly limited due to that knee pain. So I have circled here, just for reference purposes, that patient in that age group has what we would classify based off this chart of a below average fitness level. But this sort of needs to be taken with a grain of salt given her limited stress test because of the knee pain, but an important sort of factor to look at when we have your results from stress testing. There, good. Okay, so patient number one's goals. So she's currently walking and has this history that we want to address to help increase her health span. So there's a few different things we want to address. So first thing is we want to make sure that she can continue exercising, and addressing that knee pain, limiting sort of training is kind of a big thing, right? So our goal here is to help them resolve the knee pain and certainly avoid anything that's going to exacerbate it. Exercise can treat hypertension. There's, we create these training plans to help reduce blood pressure in the long term. And we have a known research that shows that there can be, as you can see in this graph here, that there's a whole range of different blood pressure reductions based off your current blood pressure, but pretty maximal with this, up to 7% or 7 millimeter of mercury in a hypertensive adult, pretty significant. And then the last one, metabolic syndrome. So this is a collective of, basically insulin sensitivity will improve, lowering hemoglobin A1C or that blood sugar, and then addressing all of our cholesterol numbers as well. Good, okay. So in remembering that this patient has sort of this submaximal stress test, it's a little more difficult to recommend heart rate training zones for exercise. It makes it a little more challenging. So for this particular patient, she came in, we talked about what she's currently doing with her 2 walks per day, one after lunch and one right before dinner. And we said, okay, we don't really know what our heart rate looks like, but we can tell what your current fitness status is at a high level from your stress test. You're not symptomatic up to the point of that particular stress test. So we're comfortable pushing you at least to that point, right? So if you have a couple walks per day, we want to make sure that the second one at least is increasing intensity so that you don't just have leisurely exercise. Really increasing that to more moderate intensity partway is important. And in this particular patient, we requested that she get a heart rate monitor to see what her heart rate looks like with exercise. She has a little bit of a vestibulopathy or vertigo when she tries to walk on the treadmill, and making sure that any anxiety related to that is reduced is also important. In relation to the vestibulopathy, we also recommended that she start some sort of strength training or Tai Chi for balance at least once a week, which she plans on doing. She's going to follow up in a couple months, sort of discuss what her heart rates have looked like on those more vigorous days of exercise, and talk about, and this is something that we go through with every patient that comes back, but talk about adherence, how they're tolerating this particular recommendations from the first time we chatted, and then give any sort of feedback that may help them out.
So I'll just maybe chime in here, and maybe if Brian and Dara have anything to add too, this is a nice discussion point, because I think this patient is actually a really common presentation. And this is somebody that is young. And I think the message that people might not hear as early as they need to is that, many injuries are not going to get better with just rest, right? We really have to be focused and targeted to figure out what the root cause of the injury is, do some, PT work and healing, and then kind of rebuild back people's exercise capacity if they've been away from exercise because of chronic pain or an acute injury. So unfortunately, when we're in our 20s and we have an injury and we're on bed rest, we rebound right back. But somewhere in our mid 40s, our rebound starts being a little slower. And actually, making strides to get back to where you were take a lot more of targeted and focused attention. So, when I'm hearing this case, I'm thinking, gosh, this is a wonderful, point that we can be really involved and hopefully make it clear to the patient, right, how concerned we are that their fitness has really fallen off, right, and make sure we're really addressing plans to get that back on track. Jonathan also brought up a couple of points too about blood pressure and metabolic syndrome. And I'm sure that probably wasn't on this patient's mind when they came in, right? But that was on our mind, right? And we know the profound effect on both blood pressure and blood sugar that exercise can have, right? So added benefit for this patient. Okay, yeah.
So our second patient is a 69-year-old male business executive and father of 2 grown children. His medical history includes shortness of breath with exertion, a family history of early coronary artery disease, high cholesterol, pre-diabetes, heartburn, low back pain, and difficulty sleeping. He currently takes Symbicort, metformin, a statin, vitamin D, and a multivitamin. His exercise history, so he's sedentary most of his young adult life. He did exercise throughout the pandemic and is currently exercising with a trainer, walking and doing some yoga. He tracks his heart rate and other biometrics through his wearables, such as his Whoop or his Oura Ring. So he came in to us for a CPET, and his baseline breathing test showed a mild restrictive ventilation. He was able to achieve a max workload of 156 watts. And his VO2 max, 19.9, was 77% predicted. He had a normal heart rate and a normal blood pressure response to exercise. He had mildly reduced aerobic efficiency. However, he did have a normal anaerobic threshold.
Great. So just in reminder, his peak VO2 max in that particular test was 19.9. So again, looking at this chart here, this is VO2 max for men. So if you go down to his age range, the 60 to 69, and then over to the oval, you see that he's right around the 10th percentile. So this is a patient who may be your sort of classic example of a sedentary patient for many years, but still carries the potential to significantly improve his life. So what kind of things do we do to sort of help him out? Go to the next slide. Great. Okay. So the first thing is there's a possible ventilation defect. So on his initial pulmonary function testing that we did right before his test, we saw this pattern that may indicate that he needs pulmonary function testing done. So we did order that for the patient. And it's important to remember that asthma and asthma incidence increases with age. So we'll look at that as a possible barrier to exercise and something that may actually be reducing his exercise capacity or his ability to perform at certain levels now. The next thing is really looking at his reduced VO2 max, right? So we know that a higher level of VO2 max can lead to longevity, and we want to help him achieve that improvement as time goes on. So we can kind of get into this, this specific training that will allow him to do that. And this is just a cool figure that just sort of says, you can achieve, up to 20% improvement in that first year. Which is going to be significant for this particular patient, and then to be able to maintain as much as possible going forward as well. Okay, so the first recommendation is, what should this patient be doing in reference to what he's currently doing now? So this patient is, his typical exercise regimen has been to exercise, 60 minutes a day, 3 to 4 days a week, between 100 and 124 beats per minute for his heart rate. And thinking back to that table that we looked at before with zone recommendation, that actually puts him at a very high zone. He's exercising quite vigorously during that period of time, for an extended period of time, week to week to week, without focus on zone 2 training that can really help him maximize that cardiorespiratory fitness. So I recommended that he, for the zone 2 training, actually reduce the heart rate for that particular time. So he's going to practice doing his zone 2 training at the 95 to 105 beats per minute range, which puts him in that aerobic zone. about 180 minutes per week. And because he can tolerate that higher intensity, and we know that there's a benefit there too, I asked him to also do sub-threshold intervals at around 120 beats per minute from 30 to 60 minutes per week. And then he also does, and I recommended he continue this supervised strength training, which can almost be looked at in his particular environment as high intensity interval training. So his heart rate will get up much higher with that supervised strength training, which he does with a physical therapist as well, and tolerating well and enjoying, which is a huge part of it. The follow-up is basically to monitor his progress, to see how he's tolerating my recommendations, and to also look at his pulmonary function test and make any recommendations regarding those results as well.
So I'll just chime in, Jonathan, that is wonderful. And, you know, you can see here that you have given him 180 plus 30 to 60 plus 2 supervised strength training, right? So we are really building something that is well over the 150 minutes, right? So, and I think that's kind of important for everybody to have kind of an open mind, right, when they think about this, because, you know, maybe if you're just starting, that seems like a huge time commitment, but I do think, you know, for what he needs, this is going to help him to achieve those goals for both the short term and the long term. And that's, you know, much more than the bare minimum, right? And we are trying to maybe make up for many years where he had been light on exercise, right? And I think that is possible. I think also in cardiology, we don't stress enough the strength training component, right? So we focus on the 150 minutes a week of moderate aerobic activity, right? But the official recommendations are to do 2 moderate to high intensity strength training sessions on top of that, right? So this is really the level of work that we would like to see from most patients.
Yeah, I think that's a really good point, actually. And this sort of goes back to our looking at overtraining. So this particular patient actually was already exercising this much when he came to talk to me. So there's really 2 pieces to making sure someone does, or 3 pieces to making sure that someone doesn't really overdo it or overtrain. There's the duration, there's the intensity, and then there's the type of activity, right? So this patient had already had this many minutes per week going. It's enough time commitment, but the wrong type of training. So we just sort of tailored it a little bit, but that's an important point. I'm glad you made it.
Okay, we'll go on to patient number 3.
So for our last patient, we have a 74-year-old female who's a retired psychologist and lives with her husband of 47 years. Her past medical history includes coronary artery disease, palpitations, high blood pressure, high cholesterol, anxiety, low back pain, and then a lumbar fusion, osteoporosis, seasonal allergies, and heartburn. They currently take ezetimibe, a statin, omeprazole, valsartan, and Zyrtec. The exercise history, so she was a lifetime athlete, a former marathon runner. She swims, she bikes, she power walks, she lifts with a personal trainer twice a week. She really focuses on keeping her heart rate up with exercise, however, has difficulty tolerating longer durations due to her fatigue. So 4 years ago, she came in for a CPET, and she had a supernormal exercise capacity, and her VO2 was 160% predicted. She then came in for an ETT, and she spent a total of 9 minutes, 30 seconds on the Bruce protocol, which equates to about 10.8 METs. She had a normal heart rate and blood pressure response to exercise, and there was no ECG evidence of ischemia. She had some ectopy, however, no significant arrhythmias.
So in talking to this particular patient, she discussed that during her most recent exercise tolerance test that she actually stopped when her heart rate got to 85% of max predicted, right? So she could have kept going. However, if you look at her METs on this particular graph in that 70 to 79 age range, it's actually above the elite, or in the elite range, I should say. So likely a little bit higher than that also, but this is indicative of a patient that has been a lifelong athlete. The important thing to note here is that in her patient history, when she first came in, she was having some difficulty with her exercise, having some fatigue and shortness of breath. So doing this exercise tolerance test, even in the setting of having a supernormal cardiopulmonary exercise test only 4 years ago, was really important to verify that there wasn't something going on from a cardiac standpoint that really may be holding her back and causing those symptoms. So what do we tell this particular patient? The goals for this particular patient are sort of threefold. The first one I want to touch on is the fact that this patient has been a lifelong athlete and now has some issues with the fact that her pace is reducing over time as she gets older. So as a runner, times are everything, and people get really fixated on how fast they can go and have difficulty with the fact that, you know, as we age, even though we're in really good health, we have issues with the fact that we're not performing to the maximum extent possible, right? So this particular patient is exercising at a very high heart rate and has a history of training-related injuries with fractures and everything and osteoporosis. So reducing the intensity of the exercise is going to be really important for her so that she continue to exercise at a high training load that she is, but also avoiding the potential for injuries. Obviously, coronary artery disease is something that we make sure that we look at. This particular patient had this subjective decline in performance in the past 4 years, but like we said, it doesn't look like it's actually specific, or our objective data doesn't support what she's feeling is related to her heart. And then obviously the anxiety piece, right? So we know that exercise resets autonomic tone and proves to decrease your resting heart rate and increases your heart rate variability, all important markers of increased health. When we exercise, we also release dopamine, the happy hormone, right? What do we tell the patient to do? So this patient is exercising at a very high heart rate for her particular age, with the idea that the faster she goes, the more she'll feel good because her pace is really high, right? So my recommendation was that she pull back her average heart rate for her runs to around 130, when really before it was really in the 140 to 160 range, because she gets this benefit, you know, she sees a positive relationship between her pace and her health, and counseling this particular patient that really the benefit of being a lifelong athlete has proven to allow her to continue to exercise. And in order to be able to continue to do that, we want to make sure that she pulls her heart rate back during these training sessions. So she's been doing that and having to sort of, you know, do some walking in between the jogging, and it is frustrating for her, but important to maintain and make sure she doesn't cause any injuries. She's also doing strength training. So we talked about the importance of that. And I think in a future webinar, we will as well. And just be patient with herself to avoid those injuries. Her follow-up will just be to monitor progress, stay in close touch to make sure that she's sticking to those sort of prescribed zones for now. And with a lower intensity and pace, just seeing how she feels about it, you know, making sure she can adhere to it, how she can tolerate it, and seeing if the high intensity interval training of strength training really fulfills that need to feel like she's going hard and really making a difference with exercise, which has been hard for her.
So this is a great example, Jonathan. I thank you for that. That I think, you know, the pairing of subjective data and objective data, because I do think this comes up quite a bit, right? If we haven't really defined our goals and we're not necessarily tracking our workouts, sometimes it's hard to know if you're making progress. And I do think this is where having an exercise tolerance test or a CPET done really helps to, you know, give you a mark, you know, of where you are and what you're aiming for, right? It takes something that feels a little bit nebulous and builds in some structure. And I do think we see better payoffs, right? When we're really exercising for a target. Yes, you want to be exercising and enjoying the joy of exercise and maybe doing something social and also checking other boxes, right? But you also want to be making improvements, right? So the idea is that we're pushing your exercise capacity, right? And that a year or 2 years, when you repeat the testing, we actually see that benefit and that improvement. So this is a great example.
Yeah, absolutely. Okay, so this is just sort of a smattering of takeaway points, but so when we look at exercising and testing and then individualizing exercise recommendations, we first kind of have to understand the patient's current level of fitness. We look at their lifestyle, we look at time constraints, barriers to exercise, whether that be the patient with coronary artery disease, a patient that has the ACL tear or knee arthritis, vertigo, deconditioning, a previous sedentary lifestyle, or simply anxiety related to exercise in the setting of certain disease state, like our previous patient had with her shortness of breath with activity, that we objectively proved that really wasn't related to her heart. As we learned with Allison's talk, exercise and being active is extremely important. The research does show this sort of dose-related benefit to being active, but keep in mind that the mindset of more is always better simply isn't true in all cases, and in fact rarely is, and needs to be tailored to the patient. So the goal is to optimize your ability to be active by using specific and often sort of periodized testing, individual metrics, often wearable devices can be super helpful, and then obviously taking into account your mind and body wellness together, which can ultimately help you feel and live healthier now and maximize your your potential to feel well into the future. And I think with that, we'll do some questions.
Yeah, that's our team there. Right. So I'll stop the share and we can chat a little and answer questions. It might be nice just to kick this off. Nicole, do you want to just say a few words about what it feels like to exercise with that mask on?
Yeah, it's not that bad. It does, it does feel different. You obviously don't have any restrictions when you're at the gym by yourself. But what I think if you do it once, you feel way more confident, and every time thereafter it'll be no problem.
So empowering for all of us, right? Because I think we really want everyone listening to be inspired to know where their cardiorespiratory fitness is and how we can objectively test that. Dr. Lee Lewis, would you like to maybe give us a bird's eye approach on how you kind of talk about exercise with your patients and the take homes?
Sure. I'm a big believer in moderation and realism and setting small goals, because I think that even though most of our patients know that exercise is super important, it's really hard to maintain that. And so setting realistic goals and not setting so high that you can't meet it and then you get disappointed. And one thing I just want to add, a recent study came out about something called VILPA, which is vigorous intermittent lifestyle physical activity. And even 3 or 4 minutes a day where you just get your heart rate up, you get a little huffing and puffing in the course of your day, maybe just running up the stairs, carrying in the groceries, vacuuming, or whatever yard work counts, and it promotes longevity. So yes, absolutely. If you can do 150 minutes a week of moderate exertion and 60 minutes a week of strength, that's great. And for some people, that's not realistic for them or sustainable for them for whatever reason. Don't give up. Still park your car at the far end of the parking lot, take the stairs instead of the elevator. Everything counts. Every choice you make to stand up instead of sitting, to walk around instead of sitting, it matters. So I'm a huge believer in that.
I love that. And I'll just share a funny story because I had a very energetic patient in last week, and she was down on the floor showing off her push-ups, and then she had me do it. And I said, thank you, because I actually had a really busy day and was sitting way too much. And I think that's a nice reminder that, even if it seems silly, like it, we should really be thinking outside the box and how we incorporate this into our daily life. I'm just going to go around. Brian, your box is next. Can you share some words of wisdom?
Sure. First of all, thank you all. I just have to congratulate my team here, or our team here. What a fantastic, passionate group who really understand the importance of prevention and physical activity, and really feel it and believe it. And it's wonderful to hear other people talk about exercise. As everyone knows, I'm quite passionate about this topic. You know, there's no, we talk about primordial prevention as far as physical activity, and you really cannot start too early in life with physical activity, and it's very rarely too late to start with physical activity. And you know, the most important thing is that this is a prescription for health and wellness and longevity and vigor and health span, and you know, the idea about living longer and quality of life issues. And as people have heard me say, we want our patients to die young as late as possible. And exercise can really be helpful for this. Couple of points, you know, when we do testing, our first and ultimate initial goal is to assess risk. And we use these tests to assess risk, whether it's electrical risk or blood flow risks or cardiovascular risks or orthopedic risk. And we want to do that very carefully and conscientiously in an environment that's safe. And then we look towards performance issues, and we have many tools at hand to help us, you know, and I think both Nicole and Jonathan spoke very eloquently about the types of testing we have. We also do other kinds of stress testing, including imaging testing and cardio imaging with echo ultrasound. And that way we can also personalize the risk assessment and then move on to the performance. One quick comment is you can be fit and you may not be healthy. And so fitness doesn't always equate to being healthy, and one has to recognize this and address all of those traditional risk factors. And I remember seeing photographs in Europe after a cycling race where the cyclists were smoking in the background, and I was thinking, oh my gosh, that's not a great healthy way to exercise. You know, taking care of traditional risk factors, cholesterol, blood pressure. And the other thing about exercise that we didn't talk really about is not only the anti-inflammatory effect of exercise, but the mood stabilizing and the mood benefits. And, you know, this becomes really important. And I think over the last several years with COVID, we've really recognized what lack of exercise does to people, and certainly the survival curves that were showing great promise over the preceding years then plateaued and now dropped. And one of the concerns is not only the issues of COVID, but the sedentary nature, you know, working remotely, being too sedentary and not doing enough physical activity. And I think we as a sick care environment, a sick care system, need to focus more about prevention and wellness. And, you know, I think this is such an exciting time for us in prevention and healthcare and personalized risk assessment, and then personalized prescriptive, you know, ideas. And I think, you know, as long as you have the basics, one needs to prescribe this conscientious, deliberate, consistent activity, because human nature is such that we all fall off very easily and very quickly. So thank you all for letting me join in.
Well said. Thank you, Brian. And I just want to actually expand on the one point that you said, because there was a number of questions that I think we've maybe answered individually, but about how the impact of exercise on cholesterol, the impact of exercise on heart disease, the impact of exercise after an atrial fibrillation ablation. And there's not a simple answer for any of those, but I do think by and large, your cholesterol, there's some cases where you're really metabolically unhealthy that we see a really profound benefit from adding exercise. for most of us, our cholesterol is what it is, and it's a risk factor that's probably really more determined by our genetics. And that might make it even more important for us to really be exercising. But most of our patients that have that added risk factor or already have established coronary disease need to be taking, their medications in addition to doing exercise. I don't think anybody here is implying that we're going to use exercise instead of the science that we have to support some of the medications that we use. That being said, I think I showed you that graph that even within the high cholesterol group, the people that had the better respiratory fitness, right, did better. So I do think we should be, charged to be that best version of ourselves, regardless of what genes we were handed. The other question that came up is with in terms of exercise in specific disease states like atrial fibrillation, and that is something that we've talked about a few times, I think, in webinars over the past couple of years. But we really do have a bulk of data to really support that exercise helps to prevent those recurring symptoms from atrial fibrillation. So I think that one would definitely be in the category where we want to kind of assess where you are and build that up as we move forward.
Although there is an association with extreme exercise and an increased risk of atrial fibrillation, but that's not what we're talking about. We're talking about moderate exercise.
Moderate exercise, and I think there are those cases where in extreme and elite athletes that we have seen some of that occur. And I will say that when I'm presenting, these slides from population data, we're not really talking about extreme athletes, people that are competing on a professional level. We're giving that term elite to the highest quintile of people that are regular people like us doing exercise. And I do think it's important to make that distinction. Okay, I'm just looking over questions to see if there's anything else we have time for.
There is a question about someone who got tested because of long COVID and got to their maximal heart rate very early in 2 to 3 minutes. And what does that mean to get your heart rate up so fast, so early in exercise? I don't know who wants to take that one.
Well, I think I can respond to that. So one of the ideas about exercise testing is to understand what normal hemodynamic responses to exercise are and what can change. And certainly we've seen after COVID, the autonomic nervous system, that's the system that controls heart rate and blood pressure, can be a little chaotic after infections, viral illnesses. And we've seen it after COVID. And it's certainly a unique type of situation that requires personalized assessment and counseling. But it can be very scary for people who are used to doing a certain amount of activity who suddenly cannot do it. And I think exercise is actually one of the treatments for this condition. And, I would say that, and I always tell this to my patients, is if you are on a regular, consistent exercise program, it can serve not only as a benefit to decrease inflammation and prolong health and vigor, and improve circulation and vascular health, but it can also serve as an early warning system. In other words, if your ability to exercise changes, we need to assess what is causing that. And people who do not do much exercise and who suddenly exert themselves actually put themselves at risk, and they have no idea of what to expect. And as we age, our ability to utilize oxygen and to maintain conditioning diminishes. I think we peak at age 28, and then beyond that, it's a downhill course. But you can slow that process down. You can really prolong vigor and health and robustness with exercise.
But I think the person's asking, so this person exercises, but if the heart rate goes up very quickly and you reach your maximum in 2 minutes instead of at 10 minutes, sometimes that's from deconditioning. I'm writing an answer here. Sometimes it's a condition associated with long COVID called POTS, where the heart rate goes up just from the act of standing. So exactly as you say, if that's an unusual response and it's not from deconditioning, we got to look a little deeper and think of all the other things that can make the heart race inappropriately. Thyroid, anemia, oxygen problems, autonomic problems, there's a whole list. So that's where your doctor comes in and says, let's dive a little deeper. You're not deconditioned. What else could it be?
So this was so much fun to have everybody participate, and I want to thank the audience for all the great questions. We hope we leave you with some curiosity, right? Curiosity to think about your own regimen, your own limitations, and what where your deficits are and what we can really build. I will also put in a plug for our next webinar because there's a number of questions on strength training, and it turns out our next one in June is going to be devoted to strength training. So work on your aerobic capacity this month, and we will get you some more details on strength training next month. But thank you everyone for joining us.